So the objective of this review was to examine the research literature that's out there and highlight the findings, and also use that as a basis to identify promising future opportunities relevant to PMDD. What we did in this review was we considered literature that was published and peer-reviewed in scholarly journals from the past about 30 or so years. So I'll present on PMDD, the history of it, and the nature of the disorder, and then I'll present on clinical care, available treatment options, and then finally I'll discuss life impact, stigma, policy, and potential future directions. So again, like I said, this considered peer-reviewed articles that were published in about the past 36 years. We reviewed articles related to PMDD, symptoms, treatment, care, and life impact. Both national and international peer-reviewed articles were included, and then there are the search sources as well. So some of the findings are listed here. Actually, all of the findings. And, we will discuss these. However, it's important to note that this selective review did not get into the nitty-gritty of the pharmacological treatments for PMDD. So what is PMDD? PMDD, or premenstrual dysphoric disorder, is a severe chronic physical and mental condition triggered by hormonal and endocrine fluctuations of the menstrual cycle. And it's characterized by cyclical symptoms that occur 2 weeks prior to the onset of menses each month in the luteal phase. We found that approximately 5 to 10% of women are affected by PMDD worldwide. And this includes individuals assigned female at birth. And reported PMDD symptoms include, but are not limited to, irritability, depression, anxiety, emotional dysregulation, lethargy, physical and psychiatric symptoms, bodily pain, and suicidal ideation. And our patient insights paper and the focus groups we conducted for that actually highlighted so many more symptoms that individuals experience. Now we're going to talk about a brief history of the PMDD diagnosis. It was first referred to as the late luteal phase dysphoric disorder, or LLPDD, and the American Psychiatric Association's DSM-3, and that was in the 1980s. And then later it was referred to as severe PMS, and then PMDD was added to the DSM-5 with full diagnostic status in 2013. And, it's important to note that there were concerns of stigmatization and harm to women in including this in the DSM-5, but they were also overruled due to findings that PMDD is not culturally bound. And they acknowledge that this is important to spread awareness of this disorder and knowledge. So with the intention of improving treatment for individuals experiencing PMDD. And throughout the world, similar prevalence rates of PMDD have been observed in other countries such as India, Germany, Iceland, I believe Korea as well. So throughout the world. So, the selective review also covered what exactly the diagnostic criteria is. And the diagnostic criteria in the DSM-5 describes PMDD, the condition, as affecting the majority of menstrual cycles, and patients have at least 5 of the 11 symptoms present in the final week before the onset of menses. And then it describes them as they typically start to improve within a few days after the onset of menses. So it's classified by the combination of 5 or more symptoms, which can be seen in the table on the next slide. A combination of 5 or more symptoms, in addition to the symptoms being associated with severe distress or social or interpersonal interferences, such as, work, social relationships, interfering with social activities, and just daily life. And additionally, the symptoms are not due to an exacerbation of symptoms from another existing disorder. And lastly, they're not attributed to the use of mind-altering substances, other treatments, or another condition. So PMDD differs from PME, premenstrual exacerbation, and PMS due to the severity and cyclical on-off patterns of the symptoms that PMDD patients experience. So PMS is defined by the recurrent mild to moderate psychological and physical symptoms, such as, irritability, anxiety, mood swings, all of that. Which tends to be more manageable than the PMDD symptoms. And these symptoms of PMS affect approximately 32% of premenopausal individuals assigned female at birth and occur during the luteal phase of menses, and again, typically resolve after menstruation begins. And PME differs from PMDD as it's the exacerbation of other existing conditions or underlying physical or psychological disorders. So it could be the exacerbation of asthma, epilepsy, depression, migraines, any of the above across the menstrual cycle that especially is exacerbated in that luteal phase. And PME, premenstrual exacerbation, and PMDD can be difficult to distinguish. However, they can most notably be distinguished by the timing in which symptoms occur in the menstrual cycle. The PMDD symptoms that we spoke about before in the diagnostic criteria occur in the 10 to 14 days before menstruation, so the luteal phase, and typically subside within the first couple of days of menstruation. And as for PME, premenstrual exacerbation, the symptoms occur throughout the entirety of the menstrual cycle, but are most severe during that luteal phase. And based on this review and other reviews, it's estimated that up to 80% of women with PMDD experience, in addition to their PMD, premenstrual exacerbation of other chronic conditions. So one thing to note that's a little bit limiting here is it's unclear whether this is based off of prospective daily ratings of symptoms. So further research would need to be done to look into that. Next, please. All right. So what's most distinct about PMDD as a psychiatric and physical health disorder is its recurrent on-off timing, the cyclical timing of symptoms across the menstrual cycle each month. And the symptoms are typically present, as we talked about, within the luteal phase, which is defined as the 14, we'll say a normal range, 9 to 17 days between ovulation and the onset of menstrual bleeding. And during this time, progesterone rises and falls within the body. In a recent study, individuals who were prospectively diagnosed with PMDD, it showed that there was a possibility of temporal subtypes of PMDD. And then using a total daily symptom score, researchers identified 3 main groups of individuals, and those were individuals who exhibited moderate symptoms only during the premenstrual week, individuals who exhibited severe symptoms during the full 2 weeks of the luteal phase, and also individuals who exhibited severe symptoms during the premenstrual week that were slow to subside. So these findings show that, we could experience some discrepancies in the diagnostic criteria for PMDD, and it might not be sensitive to potential differences in symptom timing for individuals with PMDD. And then, the etiology of PMDD, there's genetic susceptibility. There's 5 major contributors: genetic susceptibility, a sensitivity to progesterone and allo, alterations in neurotransmitters, structural and functional differences within the brain, and then also increased trauma and decreased resiliency along with inflammatory markers. So clinical care for PMDD, patients are typically treated by primary care physicians, OBGYNs, and mental health professionals, one of those. And medical professionals at RCOG agree that patients may benefit from the treatment of a multidisciplinary team, so a combination of these providers working in unison to treat an individual's PMDD. There are currently multiple diagnostic and screening tools available for PMDD. So there's the DSM-5 with 2 months of daily self-ratings. There's the PSST, which is the premenstrual symptoms screening tool, the Carolina Premenstrual Assessment Scoring System, the CPAS, the daily record of severity of problems. And then there are also mobile applications that are available to patients to help with the tracking of these daily self-ratings, because 2 months can be a long time to, keep track of all of these symptoms in great detail. And it's important to note within clinical care for PMDD that PMDD can't be detected through any typical blood, hormone, or genetic testing yet. All right, so we have various evidence-based treatment options that range in effectiveness and also in invasiveness for PMDD that currently exist. It was found that treatment, especially during the luteal phase, may be most effective in reducing PMDD symptoms. So treatment options include SSRIs to target the luteal phase serotogenic deficiencies, also hormonal contraceptives, hormone replacement therapy, GnRH agonists, so chemical menopause, a hysterectomy, or a removal of the uterus or ovaries, which is a more invasive, very invasive treatment. And then also non-pharmacological treatments such as CBT, cognitive behavioral therapy, dietary changes, lifestyle changes, and other holistic options that currently exist. And this further highlights too, especially the, invasive treatments, the need for further research into different treatment options for patients with PMDD, and possibly more targeted treatment approaches. So now we're going to look at PMDD across the life cycle. PMDD can occur at any point after the onset of puberty and occurs for an average total of 37 years. So the onset of menses to menopause. And adolescents who have reached puberty are at greater risk for depressive disorders, thus justifying the need for early screening of PMDD, which we can talk about in the policy implications later. And some women anecdotally report the onset of PMDD after stopping or changing hormonal medications. So not necessarily that their PMDD started at, 14 or however old they were at the onset of menses, but after a change in medication and hormones. And also, women have anecdotally reported that PMDD worsens with age, especially during the perimenopause phase. And this may be due to the variation in menstrual cycles and hormone levels as they approach menopause. And, PMDD, it's been reported that PMDD symptoms typically do resolve themselves after natural and chemical menopauses, but also cases have reported that these symptoms have not fully gone away after those occurrences. Life impact was a really big section that I found when doing the selective review. With suicidal thoughts and ideation and planning and attempting suicide, it was strongly associated with individuals experiencing PMDD. And it's important to note that this was found completely independent of other potential psychiatric comorbidities. Also, just so you know, this may be triggering. So if you feel that you need to, mute me for a little bit, that's okay. I'm not going to go in depth, but a couple facts about this. So it has been estimated that approximately 30% of women with PMDD have attempted suicide at one point in their reproductive years. And additionally, women with PMDD are approximately 70% more likely to have suicidal ideation as compared to women without PMDD. So that is a major life impact, living with those feelings. Based on the global burden of disease, it is also estimated that women with PMDD experience approximately almost 4 years of disability-adjusted life years. So almost 4 years of life lost due to PMDD. And another study analyzed data on patients with PMDD to calculate the quality adjusted life years due to their disorder being untreated. So due to living with untreated PMDD. And the findings revealed that even when accounting for times with periods without menstruation, periods of lifetime without menstruation, women experienced approximately 3 years of life lost between symptom onset and menopause for untreated PMDD as well. So that's a lot of years of life lost due to the experiences of PMDD. Difficulty with concentration, low self-esteem, heightened emotional sensitivity, and stigma also make it difficult for women with PMDD to work during their luteal phase each month. And the physical and psychiatric symptoms of PMDD have been reported to be debilitating, causing women to miss out on days of work and school, depending on what point they are at in their monthly cycle. And due to these interferences and potential loss of productivity, many women with PMDD have, been made to either voluntarily or involuntarily take leaves of absences or permanently leave their jobs and education due to their disorder. And then also when examining the quality of life as compared to social functioning and interpersonal relationships with family members, romantic partners, children, it was reported that women with PMDD suffer impairment that is as severe as women with chronic clinical depression, and that their luteal phase adjustment to social and leisure activities is even worse than women with other types of depression. And these impairments, physical symptoms, impulsivity, low self-esteem, isolation, and other difficulties with emotional regulation has the potential to lead to difficulties in maintaining interpersonal relationships, again, with friends, family, romantic partners, coworkers, all of the above. The burden associated with PMDD also includes a disruption in parenting during symptomatic points in an individual's menstrual cycle. And this can be attributed to severe impairments that individuals face during the luteal phase, which may lead to self-isolation, irritability, a lack of energy or self-deprecating thoughts, and feelings of being overwhelmed, all of which can affect one's ability to parent. And there's also the financial impact that individuals face, not only the financial impact of seeking out treatments from multiple providers, or the cost of insurance, or the cost of trying different medications or surgery to try to help PMDD, but also the financial cost of not being able to work or not being able to complete your education. That takes a huge toll on one's finances as well in their PMDD journey. So PMDD as a disorder itself can be traumatizing, and nonetheless, PTSD or post-traumatic stress disorder is often a comorbidity of PMDD. One study evaluated the relationship between past sexual trauma and PMDD, and it was a small sample study, but it suggested that past sexual trauma may be associated with greater reactivity, physiological reactivity to mental stress in women, and that the biological correlates of this trauma may present differently and more prominently in the luteal phase for individuals with PMDD as compared to other individuals and during other phases of the menstrual cycle. So this suggests that past trauma may be retained and encoded in the brain, heightening the stress response for severe stressors that may no longer exist as a threat. And other studies have revealed a cyclical pattern that appears to occur when stressful life events happen and exacerbate PMDD. symptoms, and PMDD symptoms can also cause individuals to perceive these stressors more intensely than individuals who without PMDD and how they may perceive them. All right. So society, stigma, and gender discrimination. While PMDD is becoming more recognized in the fields of psychiatry and gynecology, many patients have reported facing societal stigma and sexism related to their condition. One researcher found that there was discrimination towards individuals with PMDD and other premenstrual symptoms, and discussed that future studies should include a longitudinal design to better assess the discrimination women go through related to PMDD, their stigma, relationships, their symptoms, and treatment over time on their journey. Some researchers have found that labeling diagnostic criteria specific to PMDD may lead to sexism towards women, and may lead to believing women are inferior, unreliable, and incompetent, which we know is not true. However, that was a true concern that people had back in the late 1990s related to PMDD. And there has been growing discrimination towards women, and research should further expand on the impact of this subject, especially on the impact of discrimination and treatment. And I found one thing to really stand out. One researcher discussed the double standard, so-called, as an inferior status that exists between men and women, and specifically women with premenstrual disorders, comparing the labeling process and saying, and I quote, "We'll believe you're feeling bad if we get to call you mentally ill for feeling bad." And he said, "Can you imagine if we did that to men?" This researcher believed that by giving women the label of PMDD in this context, it would perpetuate stereotypes and stigmatize women rather than addressing the biological cause of their anguish. This discrimination has led to a prolonged period of receiving the diagnosis. And some people with PMDD don't receive a diagnosis until the disorder gets extremely severe. We know that PMDD doesn't make anybody inferior. And I think it's important that we continue to have these conversations to, expand knowledge of individuals out there, reduce stigmatization when talking about PMDD and other premenstrual disorders, and really do justice by the patients who are experiencing this disorder. And additionally, individuals who were assigned female at birth, but maybe transgender, have experienced negative experiences and social stigma when trying to receive care. So transgender, non-binary, and gender non-conforming individuals have faced prejudice and discrimination in the pursuit of healthcare, which includes pursuing PMDD. And in addition to this, transgender and non-binary individuals may also have different experiences with their menstrual cycles and PMDD, and may experience additional distress with their PMDD as the experience of menstruating and premenstrual symptoms may be an unwanted reminder of them being, assigned female at birth, and it might not align with what they identify with currently. So a step towards promoting the inclusion of individuals assigned female at birth who may identify as transgender, non-binary, or gender non-conforming who have PMDD is to have more inclusive language in the healthcare setting rather than specifically cisgender language to address individuals with PMDD. So there are currently some studies underway, some PMDD research at Mass General Hospital and the National Institute of Mental Health, also at North Carolina School of Medicine's Department of Psychiatry, and the National Institute of Mental Health and Johns Hopkins. And several observational studies related to PMD are underway in the United States. The one at Mass General Hospital is enrolling patients to better understand the role of hormones in menstrual-related mood disorders, namely PMDD. Additionally, the National Institute of Mental Health has a lab that's examining the causes and treatment of PMDD. Similarly, the University of North Carolina's School of Medicine is investigating the cause of PMDD and looking to help guide the development of future treatment interventions. And lastly, the National Institute of Mental Health, in partnership with Johns Hopkins, is focusing on the effect of sertraline on women with PMDD's physiologic arousal and acoustic startle response. So it's really inspiring to see that research is, being done and is underway. I think it's really important that these large institutes are conducting this. So we have identified promising future directions in our review for PMDD research, and those are as stated on the screen. So community engaged and patient-centered research, having patients at the center of everything that we do to help, bring light to the true patient experiences, what they find important in their treatment and in their journey with PMDD, and what they value as patients and what they want answered. Also looking into the efficacy of natural, holistic, and minimally invasive options for PMDD treatment and symptom reduction. Early detection and intervention provides a huge opportunity to, really face this head on from a young age and hopefully, provide interventions sooner to individuals. There's opportunity to develop a decision support tool, also a collaborative care model amongst providers. There are opportunities for longitudinal study designs and studying differences in gene expression in subpopulations, diverse populations, and also individual factors. And then also looking into further behavioral health interventions for PMDD and further research on life impact. Also with this, we put forth, some ideas for policy implications so we can reduce stigma, again, by including more inclusive language in the way that we treat patients with PMDD, so not strictly cisgender language. We can implement widespread community-based education, so in school-based health education, in primary care settings. When you go for your annual physical, we can talk with individuals about PMDD and the symptoms and signs. We can implement standardized provider education for, OBGYNs, medical doctors, like general medical doctors, I should say, mental health clinicians, everybody in the field. We could have standardized provider education to help them better identify PMDD in patients. Potential policy implications too include insurance coverage structure and treatment policies, potentially a reduction in healthcare expenditures on PMDD treatment and care, and then looking into disability policy, as we've seen that individuals with PMDD have, been voluntarily and involuntarily forced to leave their jobs, their places of work, due to their PMDD symptoms. So how can we adjust disability policy to help accommodate for that? And, as to conclude, many research gaps still exist in the world of PMDD. We believe that further research should be conducted to gain knowledge of the patient's perspective and, include their PMDD experience, treatment preferences, and goals when doing so. And we believe that involving the patient and their preferences in PMDD treatment may improve outcomes and reduce days of life lost due to the impairment from this disorder. And then my email is right there. If you have any questions, comments, thoughts, you want to chat, feel free to email me, amandamyers@iapmd.org. And thank you all. And now we're going to hear from some more of our patients.